I'm so pleased to introduce you all to Keely Powell and Sergeant Peter Weisner. Keely Powell has worked for St. Joseph's Healthcare Hamilton since 2015. As a mental health worker within the Mobile Crisis Rapid Response Team, or MCRRT, her work has provided her with frequent opportunities to attune her professional acuities to fluctuating times and environments. There are many challenges within this role surrounding systemic determinants and disadvantages towards private and public health and safety. Keely appreciates the opportunity to appraise, mentor, and confront societal inequalities and injustices through variable optics. Social work is a dynamic scope of practice that promotes social change, development, and empowerment of all people and communities. And Keely's goal is to contribute to constructive social change through pioneering means, learning, and unlearning how to navigate amid the divergent socioeconomic structures. Sergeant Pete Weisner started his career working as a correctional officer and then proceeded to his police career. For the last 21 years, Pete has been a police officer with the Hamilton Police Service. Pete's career has taken him from uniform patrol to vice and drugs, then seconded to the RCMP for an international drug investigation. Upon returning to patrol, Pete eventually found his way to the Crisis Response Branch as a social navigator. During the 3 years as the social navigator, Pete created inroads and fostered relationships with community partners to help those most marginalized to get the navigation they needed. In 2019, Pete took on the supervisor of the Crisis Response Branch, which oversees COAST, MCRRT, and the Social Navigator Program. Additionally, in April 2022, Pete and his team were the successful applicants for an $8.3 million provincial CSP grant, which will pay for the salaries and partner police with social service workers from Hamilton's community agencies proficient in the field of addiction, mental health, and most importantly, homelessness, to work directly alongside the police. This partnership will allow the most critical stakeholders safe access to the front line to tackle issues related to the marginalized triangle: homelessness, addiction, and mental health. Please join me in welcoming Keely Powell and Sergeant Pete Weisner.
Thank you. Hello, everyone, and thank you very much for having us here today. It's a pleasure for both me and Pete to be here, to be able to talk with everybody and to really focus on the transformative work that we're doing in Hamilton Region. So maybe we can just start with a little bit of what the Mobile Crisis Rapid Response, how it evolved, starting with a little bit of the past, present, and future context. Unfortunately for Hamilton Region in 1997, what propelled action between mental health and police services was that our services, both health-wise, police side, as well as community and social services, were very siloed, unable to share information, even preventative information, to unfortunately avoid tragic situations that we've seen. In 1997, that tragedy came to Hamilton in the form of 2-year-old Zachary Antidormi. And this was a toddler who, unfortunately, through his death, was a catalyst of change after his tragic murder that involved a lady in the community who was actually his next-door neighbor who stabbed him to death. Through this catalyst and this propelling of change came the opportunity for mental health services along with police services to take a look and say, something is needed here, something is missing here, and how do we fill that void and that gap? In 1997, Hamilton propelled its crisis outreach and support team. And this program provides services to people experiencing crisis related to mental health and addictions. It's a unique partnership, the first actually of its kind, between a police service and a mental health or healthcare agency. And it involves propelling an ununiformed police officer, partnering them with a mental health worker and social worker, nurses, and occupational therapists to respond to any kind of concerns that come through community, professionals, individuals themselves. This organization runs 24 hours a day, 7 days a week for telephone support, and it has a unique mobile system as well, a mobile outreach team that assesses cases on a case-by-case basis and responds as needed in our community. However, in saying that, as we know, mental health and addictions have become more prevalent in our society. There is an overwhelming need, and yet, unfortunately, we're running behind. So to advance and, again, propel our ability to reach right people at the right time and the right place. The Hamilton Police Services with St. Joseph's Healthcare looked to fill that gap by initiating a crisis response team that brought both a mental health worker working with a uniformed response team in the moment to critical crises that come through 911 response. In the last 2 decades, we can proudly say that many community agencies have joined both the COAST and MCERT networks, and we strive to ensure the proper care is provided in the most timely manner. So to turn it over to my partner here, he's going to talk a little bit more about the transformation of MCERT.
Perfect. I'm going to transition a little bit between myself and Keely, but before I get into a little bit about the history of how we got to where we are today, I'm going to take you down the road of the past. The road of the past comes with a joke, as most cops know how to tell. So I'll start with this cop walks into a bar, right? Cop walks into a bar, and what does he see? He sees somebody pulling a knife out of their jacket, ready to stab an intended victim. The officer who's responding sees them, tackles them, arrest, a life is saved, a metric is captured. Police did their job. Police officer walks into a house, sees a domestic happening. Female officer sees the unintended victim ready to be assaulted, stops him from happening. They arrest the suspect, and a metric is captured, a life is saved. But what happens when a police officer walks into an encampment? Let me take you down that road because I've been there. I've seen somebody ready to put a needle in their arm. And I've had that conversation with them. Why are we doing this? What can we do to change the narrative where you are? And the reality is when you walk into an encampment, you're dealing with suicide, you're dealing with you're dealing with suicide, you're dealing with mental health, addiction, homelessness, all those other pieces of the puzzle in which we're asked to police. But is it a policing issue? And that's the question. What we want to do is we want to change the narrative. We don't want to be the first in line. So why can we not change the narrative and say a nurse walked into a shelter or a social worker walked up to a park bench? And that's the narrative we want to change, and we have ideas on how to change that. So to give you a little bit of a history in regards to the Hamilton Police Crisis Response Branch, it is a small multidisciplinary team of uniformed officers and mental health workers working together to respond to emergent 911 calls for service. As a history, for people that don't know, I'm sure a lot of people out there, as well as in this room, have heard of the history of COAST, the Crisis Outreach and Support Team. Hamilton was the very first police service in Canada to launch that program 25 years ago, as Keely said, unfortunately on the heels of a very tragic incident with the death of Zachary Antidormi. You fast forward to 2011, we were the very first police service in Canada to partner with our emergency service to roll out a social navigator program. And what that is, it's a partnership between the Hamilton Police and and EMS, where we actually go out into the community and deal with the marginalized triangle, so the homelessness, addiction, and mental health. And the reality is, we are a jack of all trades and a master of none. And there are people that have gone to school, there are people that have taken the training to be the first in line, and we want to afford that opportunity, and we know that the time is right to bring that together. You fast forward to 2014, we were the very first the very first police service in Canada, again with the partnership of St. Joe's, to roll out the Mobile Crisis Rapid Response Team, the very first one in Canada. So we know as a police service that we know how to best mitigate risk. We also know that partnerships are key. We know that we are not going to get anywhere moving forward, whether it comes down to mental health, addiction, or homelessness, without those community partners and those key pieces of understanding that we cannot be everything to everyone. We understand that there comes a time and place where the lanes of traffic have to tighten up with policing. We've been asked a lot over the last 20 years with a lot of closing of mental health facilities, or whether it's the increase in drug use. We are now being asked to go and police people who are in tents and parks, and the reality is it's a social issue that isn't necessarily a police matter to address. We know that we need to be part of the solution, but how does that look? And we'll take you down that road when we get down to what our 2022 plan is. So I'll pass this back over to Keely to talk a little bit more about the community response with this.
I think it's kind of funny how everybody has to adjust their vision because of the difference with height over here too. So like Pete was just saying, some of what are we looking at now? From a transformative position, we are working within our community that is used to St. Joseph's Healthcare and is used to the Hamilton Police. But we really are trying to send this message and convey it very strongly between these two organizations, that health is a community responsibility and it is requiring an all-in community approach. The great thing about Hamilton Region, very proud to be part of it, is that we do have a lot of community services and a lot of support that also agree and have seen many changes in the last 20 years as to how we can practice and how we can do our job and how we can do this better. So right now, MCERT is looking to increase the community health networking and liaison, to create new pathways to enhance both private and public wellness. Well, what does this look like? Well, my partner's going to get into that a little bit farther for us, but it's one of these things where no longer are the healthcare agents actually acting as the advocates. I have to say that I am extremely proud to be part of Hamilton Police Services. And under the right leadership and direction, same with St. Joseph's Healthcare, it is putting it back into the community and saying, what is it that we can do and what can we build together? And we are getting a lot of innovative responses and a lot of people that are now wanting to conjoin services and supports. We do practice a first response model. We emphasize the mixed crisis response and management methods during crisis contact. And simply put, what does that mean? St. Joseph's Healthcare, health, policing, safety. We are bringing in both factors that are necessary. It's the least intrusive measures. It's one of those things where I am no good to anybody else if I am unsafe myself. So bringing that health and safety perspective front line, utilizing crisis intervention training and eclectic strategies and supports through both the professional and non-professional avenues normally comes out with the best practice approaches. We are all about alleviating the presenting crisis and identifying the more significant social determinants of health generating the emergency. One of the greatest successes I am seeing right now, and I am just inspired by this, is to work within a non-professional organization that I am now hearing terminology like social determinants of health. And I'll show on to a scene and we'll show up to a call and I have a police officer with no human services training that says they've been homeless for this long and this person using first name and they need this, and I called here and I'm seeing contact numbers and pamphlets that are being utilized by these services and these professionals, which also helps a professional like me to be able to hone in a little bit and dig a little bit deeper in that moment to see what other professional supports would help with fluidity of care. Our ultimate goal is to take a look at the person, the place, and see how we can take those next steps to not only alleviating the crisis, but to provide an intervention and an opportunity for continuity of care. We really are also looking to tap in to increasing knowledge mobilization and global recognition of mental health as health. We have to stop looking at it like a mere component. And the one nice message that we are constantly using between our teams now on the job, in the moment with people, is removing that stigma and being able to say to people, health is health, health and safety, this is what we're about, and how can we help you? And we're also looking to promote that social responsibility, to create an opportunity to prevent harm to oneself and others. We're looking to mitigate the risks, address vulnerabilities that can cause permanent impairment, and unfortunately mortalities that do occur. We look to increase public and private health and wellness, not just regionally. The wonderful thing about Hamilton is we're innovative. We're never going to stop innovating. But we also welcome calls, community canvassing or exploration. If you're in a region that doesn't have this available, you're looking at some kind of plan, we want you to call us. We want to help to promote this across Canada and internationally as well.
People know how to call 911. It's an easy number to remember. People call 911 for every reason that you can imagine nowadays. 80-year-olds with dementia. We're responding to their crisis as police officers because of the mental health component to that. These are the areas of lanes of traffic, I should say, that we understand we shouldn't be in. My grandmother should not have a police officer showing up at her house because she has a physical or physical impairment or a medical impairment. And this is where we have to change that narrative. But in order to change that narrative, we also understand that, again, like I said before, we have to be a part of the solution, and we have to be able to want to accept the change and accept the fact that, hey, maybe people are right in understanding why are police doing this. We should not be there. And we're very good at least in Hamilton, we're very good at comprehending and knowing where our services should be directed. So to paint a little bit of a picture about how we've worked together historically and what our mental health teams are like, and to paint a picture of what the numbers truly are. In 2021, our mobile crisis rapid response team, so that's 4 teams that work daily. We have an 8 to 8, a 10 to 10, a 1 to 1, and a 4 to 4 that cover 20 hours of service in the community. And that is a police officer partnered with a mental health worker in a police car in uniform responding to person in crisis calls. Again, we were the very first police service in Canada to do that. We know that there are also 3 different types of police officers when it comes to training. For those that aren't aware of what CIT training is crisis intervention teams. It was based on the Memphis model out of Tennessee, where they realized that there were too many police interventions where lethal force was being used, and there had to be a way in which we could do better, which is where the crisis intervention team training came in. So we are, as a police service, have approximately half of our police officers trained. We're looking to have 100% of our officers trained. But what CIT does is it gives the officers more tools on their tool belt to help them deal with when they're dealing with de-escalation and people in crisis. So as a little bit of a history here when it comes to numbers and making sense of it all, our historical apprehension rate, as you can see on the screen, is 75.4%. So that means officers that are not trained CIT-wise, so 2 brand new police officers out of police college first couple of years, or officers that have never had CIT, 3 out of 4 times they interact with an individual in crisis, they're going to apprehend. Now, if I were to get 75% on the math and bring it home to my parents when I was young, I'd probably get spaghetti and meatballs for dinner. I'm not going to get spaghetti and meatballs for dinner for apprehending people 75% of the time. That is a huge number in which we realize now we could do better. How do we do better? Well, I'll tell you, you don't see the number on the screen. 50% is the historical apprehension rate of officers who have CIT training. So we know that when we give officers training, they utilize the types of training that they received in order to de-escalate and not necessarily apprehend, bring them to a hospital based on their social determinants of health, and put them into a queue to go get assessed. And we know that only 20% of the apprehensions we bring in are actually formed, if that makes sense. So what I do want to say, we see that 12% up there, and I'll tell you where that 12% is derived from. That is our historical low apprehension rate of a quarter of a year utilizing the professional ability of somebody like Keeley. Having somebody who is trained in the mental health field as a mental health worker, who can actually respond in real time with police officers to deal with that person in crisis. That historic 12% low came back during COVID, but in fairness, our apprehension rate for our MCERT teams are about 20%. So it's a 55% decrease in apprehensions just by having a more qualified officer, a more trained officer, and putting that key integral piece at the front of the line when we're responding to these persons in crisis. We also know that by doing so, it's promoting awareness to the social determinants of health and best practices, and it also builds a rapport with our community members. We know that in order to make, and it's still change, we have to have the buy-in from our community partners, and you'll see in the coming slides how that actually happens. The big thing, especially with our Social Navigator program, which is another component that I'll speak of, is to reduce the reliance on the judicial and healthcare systems. By navigating the clients towards appropriate continued care, to avenues to improve the health, safety, and quality of life for all citizens. So we know that somebody who is homeless, living in a tent, likely using drugs, is going to be dealing from mental health. How do we best deal with that? Well, I'll tell you how I dealt with it. As a social navigator, I said, we need to get them into a place that they can call their home. Not a shelter, not a tent, not overinflated $1,500 a month bachelor. For example, in Hamilton, we have the YMCA. It's the only YMCA that I know of in North America, I could be wrong, where we actually have rental availability. So for $427, there's a room. And we've actually housed up to 80 people, from my last count, different individuals that could not sustain housing, and we've actually taken on the ability to help get them housed. So we know that building those bridges with YMCA, St. Joe, CMHA, CAMH, Hamilton Regional Indian Center, so on and so forth, our community partners, is going to help us manage to do our job better. And that's what we as police officers and police services need to understand, that it puts the right people in the right place at the right times. back over to Keely.
So looking at some of our strengths, barriers, and challenges. Well, one of the things I really like to focus on is the fact that we have built a name for ourselves in our community. So it is really nice to be able to get calls from within our organizations for advice and guidance, as well as the external. The other strengths that I also see with our program, especially from the St. Joseph's Healthcare side, is going through processes of apprehension allows us to build internal relationships and networks as well, from our emergency department to our residential doctors to new nurses that become more familiar and acquainted. And we've noticed that there is always an opportunity for people to give us a call or ask us in the moment questions. So again, coming back to that networking and liaison, it's not just happening from one side, it's happening all around. And the more comfortable and confident we get with these kind of program initiatives, the better, I think that truthfully, the feedback I'm receiving from a lot of clients is they're being valued, they're being seen, they're being heard, which through a healthcare system it's validating in itself when so many people will vocalize feeling not heard or not seen or not believed. So building competency within the differing social systems, not just health, not just education, not just policing, internal and external, requires an ongoing process of how do we learn about each other, and on top of it, what can we do together, especially around a lot of the boundaries and barriers that exist within organizations, especially around things like information sharing and healthcare silos, or consent and confidentiality. So I think that was one of the biggest things that Pete and I have kind of discussed over and over again, is we do still have to work within a system where we recognize the limitations. I love that slogan, know your limits, play within it. But I always like to say that where there's a will, there's a way. You can look at things that are concrete and still work within the concrete, but in creative ways with differing perspectives. There's a way to kind of make an inch, or take a few steps towards something that can be new, right? Crisis intervention training with the police, it became a mandate for Hamilton in 2005, like Pete was describing. And since then, it's become 4 times yearly, offered yearly, and offered prioritized to those that are first line, such as the action teams, the crisis response teams, anybody that even has a general interest come closer to, the middle of their career. We have often direct and recurrent contact with mental health clients and vulnerable persons in the community. And police and social workers and outreach teams are really the only ones on the front line that get to, intervene and communicate and contact and come into contact with these individuals that a lot of times are not seen, are not visible. Legislation and lawful restrictions is another one, specifically around, there's always a lot of questions around grounds warranting apprehensions, the Mental Health Act, right? We know that the Mental Health Act legislation states it's taken out a few words regarding imminent, but it still has to be a matter of acute. So one of the strengths is that working together between police and St. Joe's, I have the ability to explain that to family, to friends, to people that are concerned in the community, to individuals themselves around those grounds and what the concerns are for. But again, there's always this debate within between police and healthcare, which came first, the chicken or the egg? And that's a big one for us in mental health. Is it the criminal versus the mental health component? Which comes first and why? So these are all debates, like I said, that continue to kind of press us to do a little bit better. The great thing about my team right now is on both sides, between healthcare with St. Joseph's being involved and invested in research and development, and Hamilton Police, is it's giving us an opportunity to practice what we preach and to ask those questions and to kind of bring it back to those organizations that tell us what's the line, what we have to do, but it allows us an opportunity to challenge in very explorative ways and to get those answers uniquely through each other. Increasing determinants of health and decreasing community resources and allocations, increased in crisis calls. We are seeing more and more complex cases, more concurrent issues are arising, especially with Hamilton, high opiate overdose and unfortunately mortality rates for Hamilton region. We are dealing with a lot of organizational caps and wait lists, which we're seeing everywhere, especially after COVID too. It's been quite a halt for everyone over the last 2 years. So in a lot of ways, we're dealing with the same systems and the same barriers that we're all kind of encountering over and over again. But what's nice about us is we're not going to give up, and what we're doing is bringing more people to the forefront, including the clients themselves. Our work includes a lot of information from clients in regards to asking for their critical feedback. Through St. Joseph's Healthcare, we often put out surveys, especially for our programs, to seek that, to say how can we do better, like we said, and what is it specifically that we can look at when it comes to transformative justice and transformative change.
So this is going to be one of the better slides because we're going to actually show you and demonstrate what we're doing. And it's just not lip service, it's actually getting off our butts and actually going into the community and having meaningful dialogue and doing things that are going to instill change. So a little bit about the highlights in the recent years, and I'll get into the future. This year in 2022, we actually increased our MCERT teams from 3 a day to 4 a day, increasing it by 25%, which was huge. That still only handles that's only about 20% of the mental health calls we can do as a city. So it kind of gives you a context to how much mental health and how many mental health calls for service the Hamilton Police are actually getting asked to intervene in. So I know that just our MCERT team, we did just under 3,000 calls last year, but as a service, that's only 20% of our calls, so puts it a little bit more into context. I'm proud to say that, and I have to paint a little bit of a picture here without the slide, we realized that during COVID, and I'll hopefully have some time at the end to review why we did it, we realized that we weren't engaging as much as we could. Everything was closed, and when everything closed, who was left? Who was open? Hospital and police. And we found that there was a huge influx in, obviously, mental health calls for service, but the fact that people were actually struggling and they had nowhere to turn to. And this was when myself, and I was a social navigator at the time, realized that we have to come up with a better way, which is where the grant came from, of helping these people who need help, the people who are just trying to find a meal and not where they're going to live. That's the struggle for some people out there. And the struggle always comes back to police. We need to help these people, and inherently, all police want to help. And it's not for a lack of not wanting to help, it's putting the right person at the right place. So we came up with a very vivid idea of writing a grant that we had systemically wrote for a non-mental health reason. It was to help, it was through the Solicitor General, so it's for policing. And we realized we got to change the narrative. So we all agreed as a service right down from our chief down that we need to do the right thing. We allocated $500,000 per year, so $1.5 million a year, to pay for the salaries of people like Keeley, social workers who are proficient in the field of homelessness or the field of addiction or mental health, to help us do our jobs more efficiently, because all we are going to do is keep these poor individuals going into a vicious circle. And I've created a term called the marginalized triangle. And the marginalized triangle is a vicious circle, but it's a triangle with 3 points: homelessness, addiction, and mental health. And somebody's going to get tossed out of their unit, and then they're going to be living on the street, and they're going to be more accustomed to mental health issues, and then the addiction piece comes in, and they go back to jail, and it's a revolving door for them. So we know that by allocating funds for social workers to work with us, it's going to help us do our job better, but it's also going to be doing the right thing, and that's what we have to really get out there, is it's the right thing to do. One of the other great concepts that we have coming down is virtual reality to improve response and decrease or de-escalation of individuals from mental health. As you can see up on the screen, unfortunately you can't click on it, but if people are at home taking notes, you're more than welcome to look at that clip that was on CBC. And what VR is, and where that came from, was based out of a research study done by Laurier University, where they realized during COVID, how are we going to train police officers to de-escalate with an individual, with a person, and you can't be in front of a person? So they came up with a very vivid idea to use virtual reality to train police officers to de-escalate. Hamilton Police, again, the very first police service in Canada to have this rolled out with this particular initiative, where we now can go back to our service and say, let us give more mental health training to officers that are dealing with persons in crisis at the front of the line. Additionally, we can also implement it through our crisis intervention training program and allow our community partners to be a part of that great technology, where they can actually be engulfed and engrossed in this training. And I'm telling you, from my experience of doing the VR training, it is a submersive. I would say it's better than live actor training when you have that, schizophrenic male who's presenting in front of you as an actor, a real true life actor, to help you in your training. This is the VR technology blows it out of the water. And we're very happy and very, very proud to be working with Laurier and the great minds over there to ensure that we're giving as much training back to the front line, to the police officers as possible. The last thing I want to touch on too is our regional research and the community research by our professional development partners, specifically at Laurier University with the VR. This also goes back to what was Ryerson, which is now the Toronto Metro University, was also a huge component of this. And our partnerships have become so great that now we're getting buy-in by people like Laurier and the researchers there to say, hey, what you're doing with RIST, we'd love to be a part of that too. So people are starting to understand the buy-in. And the buy-in comes from the marketing, but the marketing, what we're doing today, comes from putting your boots on the ground and doing the right thing and making sure that as a police service, we're also listening to our community partners. We're listening to our coworkers saying, how can we do this better? Because we know we can't be everything to everyone, and there's a way to do it more efficiently, and this is what we're doing. So we're proud that this rapid intervention and support team is coming down. What it is real quick, it's a partnership with right now 6 different community partners in Hamilton. Let's see if I get all the names right. St. Joe's, of course, Canadian Mental Health Association, YMCA for Youth, Interval House for Female Housing, Wesley Urban Ministries for Male Urban Housing, Hamilton Regional Indian Center for Aboriginal, Indigenous, and we also have, it's always the last piece, Indwell. No, not Indwell. My apologies. I should have had this written down on a slide. CMHA, who's in there for the addiction piece. So we have everybody that when you could truly look and step back and say, what does an individual need? What pieces of the pie do we need to bring to the table? We have all these community partners that prior to getting the funding, prior to us writing for the grant, they were already at the table with us with commitment letters saying, hey, when and if we can get this off the ground, we want to be a part of the solution too. So it's great getting out there in the community, but more importantly, being a conduit for me to a police service to say, how can we do things better? And that's where I'm truly blessed to be able to have the ability to help build the bridges to these community agencies that essentially are doing the same thing we're doing, just in a different silo. So what we're doing is ripping down the silos, or taking down the silos, and working together in a more holistic setting where we know that by putting the right people at the right place at the right time, we're going to do things a lot better.
Just to go back on that a little bit too, from the St. Joseph's Healthcare side, we recognize, well, I think from the Hamilton services as well, we can't do everything like Pete said, but one of the things we can also do is take a look and say, well, maybe not everybody wants to deal with police, or maybe not everybody wants to deal with St. Joseph's Healthcare. So one of the things that we are focused on as well is COAST program in collaboration with St. Joe's is organizing a non-police response model. And this is to honor youth and individuals that may feel uncomfortable or discomfort working with certain bodies for whatever reason. We're really going out of our way to take a look and say, okay, we want to alleviate a crisis, we want to alleviate that discomfort, but we still want to reach you. We still want to be able to connect with you and offer you support. So what does that look like? So that non-police response model would consist of either a triage worker or 2 mental health workers that go out when a situation is being safe to go out and provide prevention, continuity of care, connections, referrals, resources within the healthcare services or social services in Hamilton. The other thing that we're actually just been doing as well recently is we have been able to offer McMaster Children's Hospital and University a pediatric resident mental health placement. One of the founding issues that we found, especially in healthcare in the last little while, is it's great to treat somebody medically, but it's so important, like we keep coming back to recognize, nobody just kind of goes into critical crisis, and it's not often just one thing. It is many things, and they are not trivial, and they come at individuals creating a distress intolerance that I think any of us are capable of having, these kind of reactions, and everybody needs help time to time. But the emphasis has to go back on the fact that we require recognition of those social determinants of health. And I am very proud to also say that within St. Joseph's Healthcare, we are seeing great advancements with our doctors walking in, our residents, our nursing staff, our social workers. We are always attempting to make sure that we are looking at the inherent dignity and worth of every person, every client, and also taking time to change our language, change our terminology, change the narrative, and refresh it not as a person being the problem, but like Pete said, acknowledging the systemic difficulties while honoring the person and seeing what we can do. And especially with young doctors, it's super helpful, and they've been great as well. I just like to say it's wonderful because the reach out that they've had with our mobile visits, they come out with our ghost team, they do ride along, and they are actually, many of their medical students are providing great feedback for us too, things that they didn't know, things that, unfortunately they haven't had opportunity or connection to. So again, another avenue we can take, we can look at that and we can tweak it. So bringing it to the fact of the balancing act, which is always difficult for us, and especially as a social worker by designation and mental health worker by trade, balancing between the principles and actions is a teeter-totter, as I like to say. We can hold ethically to our tenets and our principles of social work. But I can honestly say and candidly say, it can get difficult at times between trying to work with a client, trying to keep, in the focus of what the client wants and the best interest of the client, their right to self-determination, when we take a look at versus, what's more relevant and what's more important and what's more attuned, the person's well-being, or is there a certain aspect of community risk now that we have to take a look at upholding the right of society to impose limitations or to feel safe and secure, right? Another thing is, of course, from a oppressive standpoint too, working within the police authorities can be a disjoint for a lot of people. So working in partnership with police, it can be perceived as conflicting towards social fairness, equitable distribution of resources, right? Reducing barriers, or is it enhancing barriers, and expanded choice for all persons. I like to say I look at myself as an advocate, not an adversary. I look at my partners, these are colleagues, they're not police officers. And the first and foremost, I think that anything we need to do is to bring forward that we are people first and a profession second. I work with amazing people, both within St. Joe's and police, that are there and focused and want to do a good job and want to enhance their community overall. So I will put myself in that position, and I will state that to both client and colleagues very often. Social workers strive for impartiality. It's a responsibility of myself to establish the tenor of their professional relationship. And it's an essential element of integrity in professional practice and ethical accountability. I think when you're working between systems too, I've experienced times where I'm like, that might not have been my first approach, or, we have an enhanced knowledge and an attunement that other professions may not, right? And that's not just police, it may be other community organizations that are involved. What I like to say, though, is what I do is I do my due diligence, and I'm constantly taking myself into those guiding principles and looking back to my tenets. And I cannot stress enough, utilizing our social work guidelines bring me a little bit more closer to my ability to adapt my responses to make sure that I'm upholding the integrity of, like I said, our college, my work, and the organizations I represent. So balancing ethics in unison with a lot of provincial and territorial standards and guidelines. Right? It's when you're apprehending somebody, we're taking away someone's rights, we're putting them in a situation where it's involuntary, not voluntary. It can be a gray zone when it sits there with the incongruence, and how I have to set forth is I have to take a look at those primary, secondary, and tertiary situations as, am I doing due diligence to the work and to the person? And that's how I bring myself back. Social workers contribute to the ongoing development of the profession. We like to service humanity, participating in the development of current and future social workers and the development of new professional knowledge. I am trying that by coming forward today and trying to come out and reach all of you guys today and say thank you so much for having us, but on top of it, thank you for letting me demonstrate and work on a new professional development that is standing up here and presenting that I'm not used to doing. So I like to say in our work, we also have to step outside of our norm quite frequently and look at working in that discomfort just like we expect our clients to do and other people to do. So one of the things we like to do is we look at how we're spreading that knowledge mobilization, tapping into universities, tapping into our organizations. St. Joe's is huge on research and development. So all of these components help us kind of guide our work. It also helps to deconstruct those social typecasts that divide versus unify us as a community. let you tap.
All right, closing remarks. I struggled to determine if I was going to tell this story. We have time, so I'm going to share a story with everybody in this room and at home. 5 years ago, I met Danny. If you guys don't know Danny, I'm going to tell you about Danny. First time I met Danny, I arrested him for drunk in public. But I knew something about him was special. I knew that I had to continue the conversation after. So when he was fit for release, I brought him upstairs and we sat outside. We chatted for 2 hours. And I talked to him about his life and where he was, and I kind of learned a little bit about him. And this is who Danny was. He was Indigenous. He was an alcoholic at the age of 8. It's not a typo. He's usually up here. It's not a typo. People are like, oh, you missed the 1 in front of that 8. No. He wasn't 18. He was 8. He has lived a very tough life. And that tough life put us in front of each other. And it was at that point, there's more to the story, but I realized at that point in my life as a police officer, and Keely said it best, we're humans first. And he's a human being, and I saw humans struggling. And I have my own personal afflictions. I have mental health and addiction in my family. And I know what it's like to be the father of this kid, or the nephew of this kid, or a friend of this kid. So I wanted to be a friend. So I spent the next 2 years grabbing a slice of pizza every 2 weeks as a social navigator, which gave me a lot of freedom to be out in the community. And I went and had a slice of pizza with this guy, with this kid, who he's now 29, and just had conversations with him. And those conversations instilled trust. I take you down to the road where we've all been, May 2020. Where were we all in May 2020? Locked up in our houses. And at the point, I had given Danny my cell number. I don't have a work number. I only have a cell number because I don't want to carry around 2 phones. So I gave him my personal cell, and he called me on a Saturday in May of 2020. And he said to me, Pete, I need you to help me stop drinking. And I'm like, okay, well, Danny, it's Saturday. I'm all for it. I want to help you out. But, why do you want to stop drinking today? What made you get to that point? He goes, because I couldn't light my cigarette. I'm like, okay, here we go. It's all right. I'm good for this. This is what I do. And he said to me, Pete, I know what you're thinking, and I'm not drunk. I said, okay, I didn't think you were, but why do you need to light your cigarette? Why do you need to stop smoking and light your cigarette? Because I can't, because my hand shakes so much that I can't light my cigarette. And I'm like, wow. But what did he do? He called a cop. He called a cop because he had a number and because nobody else was open. Nobody else was open. So I said, man, I got to help this guy even more. So I helped him. I tried to put him in touch with resources, but resources are closed. So all those resources that we would normally rely on weren't there. So I became a one-stop shop for Danny. I helped him with his food banks. I helped him with this. I helped him with that. We ended up getting him into the YMCA where he's actually really good. And I probably had the most compounding conversation that I've had with anybody in my entire life. And we're sitting in his room at the Y, having a coffee, and he says to me, Pete, I need you to know something. I said, what's that? He goes, and I missed a key piece of the story. He actually found his mom, who had committed suicide when he was 12 years old, right? So he said, Pete, I need you to know where to find me if I ever commit suicide, which took me off my feet. I'm a pretty soft guy, so I'm trying to hold it all together and not cry. And, of course I said to him, Danny, why are you telling me this? And I didn't know. And I only ask questions I don't know the answer for. I don't tell my kids that. And I said, well, why are you asking me, or why are you telling me? He goes, because I know that if I do this, you'll find my body and I don't want it eaten by the animals. And I'm like, wow, he's put thought into this. And for the next 7 months, this was the spring, it was March when he told me this, I walked up and down. People don't know Hamilton, but we have an escarpment in Hamilton. We have stairs that go up and down all over. And I realized I got to go find this noose hanging in the tree, because he said that's what he was going to do. So I went up and down those steps 17 different times. And every time I went up those steps, I was wearing a uniform too, and I'm not in the best of shape, so it wasn't fun. I got into the summer, and of course you can't see anything because of the shrubs and the leaves, and then I decided to go up in the fall. And it was the 17th time that I went up there. I said, I'm going up the wrong stairs, because what am I going to do if I find this noose hanging in a tree? I'm going to take it down and say, ha ha, you can't do anything. Well, that's not the truth. The truth is, if he's going to do it, he's going to do it. I don't need to go up these stairs. I need to go up the stairs he lives in to be more a part of his life. More importantly, I got to bring those support pieces with me to walk up those stairs to help Danny get those wraparounds. Because we know, at least from my experience, the number one flaw and failure to dealing with the marginalized triangle is not having the proper wraparound supports. So what we're doing with COAST, what we're doing with MCERT, what we're doing with our expanding rapid intervention and support team is putting the integral pieces to the puzzle at the front of the line to help pieces like Danny. And I knew 5 years ago I would be standing on a stage somewhere talking about Danny's success. And here I am 5 years later, and I plan to be 5 years later from now with Danny on the stage talking about his successes. And it all comes down to one thing, community partnership. And when we can put indifferences aside, me and Keely were talking about that, we're going to have indifferences. People are not going to have the same theories, and debate is good. But what's even better is that when you could put those aside, come together as community partners, whether it's police, social workers, addiction specialists, mental health workers, anybody in the community that wants to be a part of the problem, we want to be a part of the solution. Or wants to be a part of the solution, we want to help change that problem. So with that, like Keely said, we thank you for this opportunity. I look forward to working alongside social workers, hopefully, for the next 10 years or maybe 12 years of my career. We're just talking about retirement. But the reality is we can't do our job without the social workers out there, without the intensive case workers that actually instill change out there. And one thing I always joke with Keely about is you're a professional, and you're the reason why we go out, because police officers are a jack of all trades and a master of none. And we're asked to deal with very complex situations in the community that we'll deal with. We can go deal with a domestic that's been going on for 30 years, but that 25-year-old police officer that's responding to him has about this much knowledge on how to make a marriage work, but we're still asked to do that. So we understand that mental health, addiction, and homelessness is much more important, and the validity to bring the intensive case workers, the ones that are the best suited for the job, to the front of the line is what we need to do. And we're proud to be in partnership with St. Joe's and all the other partners within our community as well. So.
And I would like to thank St. Joseph's Healthcare, and I hope all of you have seen. Pete Weisner is a police officer, but as you can see, he is a human first, and I think he has strongly demonstrated what I have seen on behalf of all of the Hamilton police officers that are currently doing their work. They hold themselves with integrity, and it's that social connection that was just demonstrated through their articulation, their dedication, and their service to humanity that carries over to all of us. So thank you.
Thank you.
Thank you so much, Keely and Sergeant Weiser. As I noted before the presentation, we're now going to have a question period, and the attendees have already been submitting their questions. We already have a bunch, so by all means, please submit your questions now through the chat feature on the right-hand side of the session page in the virtual portal. Goodness, sorry. We will do our best to answer as many questions as time permits, and we thank you for understanding if we do not have time to answer your question. So in order to accommodate questions from as many members as possible, we ask that you limit yourself to one question only. And so I'd like to start, as I said, we already have a bunch that have come in, but a question we've been asked is, how is MCERT supporting and responding to those living rough when they are faced with the crisis of being evicted from their encampments?
That's a great question. It's not MCERT that's dealing with them. So that's the first question. The second part of the answer is our social navigator team does it. And I didn't put a lot of context into what social navigator is, but it was that piece where I said it's the Hamilton Police in partnership with EMS. Well, that partnership's grown to housing workers, to actually 5 paramedics and 5 police officers, and our RIST pilot model is, so all those different agencies that I said, the Hamilton Regional Indian Center, CMHA, St. Joe's, they're actually coming on board. So like Keely, you get your little pass to get in the front door, you pass all your clearances, you're actually coming to work and respond to those persons living rough with a Keely at the front of the line. And here's the best part. We're going to work it as such, so when we triage the individual that needs to be seen today based on a referral, we're going to say, well, we know John Simpson, who's make-believe. John Simpson is not a risk to anybody in the community from a social worker standpoint, so guess what? Why don't we get the mental health worker expert, and why don't we get the housing expert to go out and deal with Mr. Simpson on his own and leave police out of this? That's what the concept is going to be for RIST, and that's what we want to do with RIST. Hopefully that answered the question.
That's great, thank you. We also have a question. I'd love to know how many places around the world are using this approach of partnering together as health and safety to provide better services. Don't know if you know the answer to that or not.
Question.
It is a great question. I know that there is, and I believe there's a UK version that is being implemented with national and international responses and initiatives. Now, they all look a little different depending on their environments, right? The US uses a similar model as well, and in Canada, at least here, I think it's pretty much nationwide that they have either a pilot going or at least some type of, like I said, model being demonstrated in at least all of the provinces across Canada. If not, and I could be wrong on that, I can get back to the person, if I know who it is, with the right answers.
Excellent. My information is on the screen if everybody wants to email me. I get about 75 to 100 emails a day, but I'm willing to take on more if anybody has further questions as well.
That's fantastic, thank you. One comment says, I see that Keeley uses a vest at times, which is fantastic. Some agencies I know do not allow its employees to use a vest, saying it will bring stigma. What are your thoughts about a vest versus or like using vests and stigma? And Keeley, you're not a police employee, I believe, and you work at St. Joe's.
That is correct.
Yeah.
So I can personally say I despise the vest, personally. It is as a worker, but it's safety. My safety is, I can't do my job if I'm walking into a situation. I like to look at it like this as well. Before coming to St. Joe's and doing the rapid response team, I worked many years ago in different regions that were doing a co-response, which was 2 workers or 1 worker in an organization going out. And it's not to say that those models don't work, but from an organizational standpoint, we were always taught, you go up there, you see something that doesn't quite look well or abode well around your own safety, what do? I could have a really unwell person that I'm here to see. And me and the other person aren't really feeling that comfortable, right? So therefore, what am I going to do and who am I going to call? It's not Ghostbusters. So unfortunately, those delays are what I would say the benefit of working both sides. With the police, it's getting you in contact faster, more furious, more on the spot in the moment with the person. The vest, we utilize a big sign that says, "Hi, I'm St. Joe's," and I often find it as an opportunity to separate myself. If I have somebody that's there, coherent, able to engage, whether it's a vest or otherwise, just by telling them and expressing who I am and identifying myself, which we do, really half the time I have to say they're not so worried about the vest once they know who I am and the purpose and rationale behind where I'm at.
And just to cover off something about the vest, I wouldn't wear a vest if I didn't have to. We're mandated through the Police Services Act to wear it. But to give you a better idea, we understand the stigma. Don't get me wrong. We get it. And we also get what it's like to have a police cruiser parked in front of somebody's house who has to have police respond 3 times a week to their 13-year-old daughter who's often going through mental health crises. We hear loud and clear. We can't inflict change right away. I've already written proposals. We're actually changing our vest plates so it just doesn't say police, which is mandated. It's going to say police, crisis response branch, police, social navigator, police, coast. Additionally, what we want to do and what we're planning on doing is transitioning our cars to turn them into ghost cars. So it's just a black Charger or a black Explorer where it's not a billboard parked in front of somebody's house saying, "Hey, the police are at your house again today." We get it and we're listening.
Thank you. Question, if there's is there regular cultural competence training offered for healthcare professionals and police officers within this team to help understand the values, the diversity, and to understand how to respond to cultural differences?
So I can comment on mine. So we, police officers, at least in Hamilton, and I know it's provincial as well, we have what we call block weeks. And our block weeks are usually 2 days of in class and 2 days of, requalifying on a use of force option. But those 2 days in class, that's put together that is determined by our command staff. So this year, for example, I know I've been in it. We've had a lot of cultural pieces in it. We've had dealing with people from the BIPOC community, understanding cultural indifferences, so on and so forth. So I know from my standpoint in Hamilton, there's a lot of training that is pushed out to ensure that we're getting the right type of training to deal with the right types of situations. And I'm not sure.
And definitely from St. Joseph's Healthcare, it's one of the core competencies that we have, refreshers and renewal training, right? I think it's definitely either on a yearly term, but they're also very much tuned into having access for all of our staff through the internet and through online lunch and learns. So there's lots of opportunity, there's lots of refreshers that way as well. We do our very best, but I think this is also another area that Pete and I are looking very closely between our organizations, that we recognize we don't know it all. And we're, you know what I mean, there's a lot of work to do in these areas, and why we're really trying to compel to the community organizations, you know, to diversify our teams and to have that unique experience and be able to do that frontline work competently and confidently. And I think we need that from on behalf of our community networks to guide us, and we're open to that learning.
Thank you. Two questions that are different but similar, so I'm going to link them together. So are there specialized domestic violence or intimate partner violence partnerships? And is there also a specialized police partnership for attending to CAS matters as well, so child welfare matters?
Yeah, that's not in my wheelhouse. I can speak from just being a police officer in Hamilton that I can say that I know that we have a domestic violence unit. It's 2 detectives that are in partnership with a lot of our community agencies that deal with victims of crime when it comes to domestics, when it comes to sexual assault, so on and so forth. I can't honestly, in fairness, answer the question fully because I've been enthralled in mental health and addiction for the last 7 years. But I know as a service, I know that we're create standards within our service, and we follow the standards that are put forward before us from a provincial regulatory body as well.
If it has to do with how much contacting and communication and involvement or MCERT, the mental health workers, would have involved with these cases, the answer is we attempt to not muddy the waters when it comes to these situations. If it's a situation where somebody is in distress or requires that support, it would go through victim services. If they needed extra support, of course, our team would definitely go to offer that support a few times after all of the criminal components have been dealt with. We try to do our best, but at the same time, there are definitely lines in the sand where we want to make sure that we are very careful not to get into something that we really can't be the be-end and all for. And we're always happy to offer like the longer term solutions and continuity of care, or at least support measures that individuals may need in those cases.
And I could just paint a little tail into that. We triage our calls. We try our best to triage our calls before we send Keely into a call, because we don't want Keely going into a domestic. We don't want Keely going into a bomb threat or anything else. We understand that complex matters that have mental health issues attached to it, we're always going to make sure that the criminal part, the criminal code, is always going to supersede the Mental Health Act, right? So if there's somebody who committed a criminal act and there's a mental health component, we can deal with the mental health component later. Right now we have to deal with the criminal code because there's a lot more pieces to that puzzle that we have to ensure we have covered off. So.
And to answer a very common question, that is the legislation. That is the, mental health provisions and enactments is a provincial matter. The criminal is a federal. So therefore, that's the reason why those aspects have to be handled first above the others.
It's a really helpful explanation. Thank you. And this is going to be our last question as well, but I can say that there's been so many comments coming in just thanking you for your presentation. It's full of hope and just really commending you for the great work that you're doing. Interesting question. How is the dynamic relationship between the crisis workers and the police officers who are responding to crisis? Are there power struggles? And if so, how do you mitigate these challenges?
I'd like to comment on that first. They are the expert subject matter when it comes to mental health. We, as police officers, are given the authority under the Mental Health Act to apprehend. That's based on three very low-grade kind of, are you suicidal, homicidal, and do you show an ability to care for yourself? And the reality is it's much more complex than asking or answering those three questions. So I can say, and I think Keely will resonate the same sentiment, they are the expert subjects matter in the case, but there is a good working relationship between us. Like, what do you think? What do you think? At the end of the day, I'm always going to put all my cards in the same pot. Like, do we apprehend here? What do you think? You're the expert here.
I like to say that's an absolute lie, to be honest with you. So, you know what? We're really lucky. I really lucky. I come into this, and it's colleague to colleague. I work with some of the best people who are just ready, willing, and we come up with little things. Like if we're both on the gray, we'll come up with little sayings. At 17, we can use codes. We can. If we need to stop, drop, and roll, like the old fire saying says, and take a moment, do you know what I mean? To just, okay, how are we feeling? We have that dialogue. nothing's ever, I cannot say that there's ever been a confliction, because by the time that we have the safety secured and the person is de-escalated, is able to kind of click in and have that opportunity to say, okay, what do we do here? We often involve the person themselves, right? So I think that the dynamics with your partnership are huge. It's human relationships. And as long as we're able to work together, we often will bring in the person in crisis, and we have this really awesome experience where it's not just us authoritating what happens. We go about this from empowering each other and empowering the clients and for good outcomes.
And the best way to put it, Keely isn't a social worker from St. Joe's. Keely is my colleague who works with me. That's the best way to put it. There's no, this is your side of the house, this is our side of the house. We know that we have one job to do at the end of the day, and we're both going to have to work together. So whether it's the Army and the Marines working together to get a job done, or A and B getting together to get C done, this is what we know we have to do.
Often the police officers are liked a lot more sometimes. So, but it goes to show, right? Sometimes people have different set-offs. It's not just, you know, oh, that's a police officer and I don't like them. I've encountered a lot of times, I think I'm pretty, you know, sweet to start with a little bit, but there's a lot of times where it's the flip side, and we have to acknowledge that I may not be somebody's cup of tea, but they get along well with Pete, you know what I mean? And that's fine. The way I look at it is, if something's open and engaging, why fix what's not broken? Let's roll with this and intermingle and to see what we can do. So we just play off of each other, and hopefully we can lead somebody to become involved in their own care as well. That's the hope.